Hey everybody, welcome to Love My Practice. This is going to be a really fun episode. We get questions all the time from doctors about tons and tons of different topics, and those of course are the ones that we're going to try and hit with you. However, today we're going to talk about associate doctors and when you want to get one, how you want to structure it, how it works, all that kind of stuff. Anything A to Z, associate doctors. We've had a bunch, and we've had good ones, bad ones, and everything in between, so we're going to talk a little bit about how we want to, what's the point, really.
Yeah, I think the biggest thing is when is it time to find an associate doctor? Like, how busy should you be? How many patients should be coming through the door before
That's the biggest question we get, yeah.
Hire an associate doctor or start looking for one. I think that a lot of times associate doctors or a partnership or whatever you're looking for is sometimes overlooked.
Well, a lot of people do it for the wrong reasons.
Exactly. Yeah. They're wanting to cut back their hours, or they're looking for an exit strategy or something like that. But then when they step back and look at things, they don't have really a ton of new patients coming through the door. They don't have all their systems refined that would support an associate doctor. So
exactly.
When would you tell people to hire an associate doctor?
Yeah, this is what I tell people is don't wait to get a feel for when you need one. Really run the numbers and be really satisfied that you're really busy enough for one. So a couple of benchmarks that you would want would be at least 50 new patients a month. That you have already coming in or that you can market for. At least, booked out 2 to 3 weeks in the doctor's schedule at least. More than that is even better. Some of those benchmarks really, you've already hit, your office is doing probably at least $1 million in annual revenue, if not more. And just really ready for growth. And you've seen some growth recently too. If you're on the decline, that would be the worst time to hire one. Yeah. There's a lot of times when I would say don't. And a lot of times it's just because somebody wants to cut back, or they're gotten tired or bored, or a lot of those things. Those would be the last times that I would hire somebody. But a lot of times circumstances dictate, and a lot of times what we find is like doctors want to bring a son or a daughter in, which is great. But that requires probably at least 1 year to 2 years planning and marketing and really getting yourself ramped up and busier before you would hire that person, even if it is a family member.
So I think the biggest thing is just make sure that you're super busy.
Yeah.
Your schedule's booked out a minimum of 3 weeks.
Right.
You got quite a few new patients coming through the door, and your hygiene schedule is as well booked out for quite some time.
Right, and I would say multiple hygienists already. I mean, at least 2, one hygienist per doctor that you're going to have would be a really good benchmark as well. I mean, certainly, this would be a time when, if you want to contact us and really kind of give us your scenario, that would be fine. And we love to talk to docs. So, I mean, anytime you want to, get in touch with us and talk to us about something like that, we'd love to help. But yeah, if you're on the fence about whether or not it's the right time for you, but if you have determined that it's the right time for you, or, a lot of people already have an associate doctor and they want it to be working better and all that kind of thing, that's pretty much what we're going to talk about now. Mm-hmm.
So you've hired one, or you're in the process of hiring one.
What do you want to think about?
How do we structure it? How do you plan for that when it comes to team, office protocols, your existing patients that will be seeing this new doctor, plus new patients that will be seeing the doctor, all of those fun things.
Yeah, right. Okay, so good times. No, this is great. We've had some of the best doctors as associates, so I definitely don't want to... we don't want to have anybody shy away from anything like this, but there are some challenges, no question.
I say that an associate doctor is just like any other team member,
right?
Any other employee that you have, because they have to know all of your protocols and what you expect. So they have to go through the office manual, they have to go through the team agreement, they have to know exactly what you expect out of all of your other team members, and also what you expect out of them. So
and if you don't set any expectations, you're going to be disappointed.
Yeah,
100% of the time.
You can't assume that they are going to know how to do things and that your team is just going to...
No matter if they're fresh out of school, which is fairly common for associate docs, or they've had several years of experience, or maybe somebody coming out of the military after 20 years or whatever, they're still going to have to train to be in your practice.
Yeah, because your practice is going to be different than the practice that they came from in the next state, or from college, or wherever they're coming from.
Well, I'm thinking you're definitely not going to love your practice if you don't set some expectations.
No, and same with team members. I mean, if you haven't set those expectations with your team members and things like that, I'd be doing that way before you hire an associate so that you have that down, and then also what you expect from doctor. And I think a lot of times people, and I was guilty of this at first as well, I assumed that associate doctors, because they had had an extended education and they were considered a professional, they had doctor in front of their name, that they knew how to be professional and that they knew how to talk to patients and team members. And I really kind of got burnt on that, which is why we have these protocols and systems now, because it's not that they didn't know how to, they just weren't doing anything versus doing what we wanted them to do.
But you're going to get, what's going to happen is you're going to get, you know, from your normal, what you're used to doing, you're going to get this big ripple effect over time of, you know, new things, different things coming in, and you want to keep it as systematized as you possibly can the whole time, because that's when team members and the patients and everybody, you know, the doctors are going to be the happiest, is when everything sort of conforms to the systems that you already have.
So have, you know, the expectations nailed down. We have an associate handbook that we've made, like our policy manual and our office handbook that we've made for just our associates. And some of the things that are gone over in that are, for example, who we refer to. So the specialists that we already have relationships with, that we're referring our patients to, that we know take great care of our patients and refer them back to us.
Right.
Goes
and
over
we've had
that.
some questionable experiences with certain, you know, other specialists. So that's there are some reasons why we don't refer to certain specialists, and they don't take good care of our patients when we send them over. So that's a huge issue, actually. I mean, it's just spelled out. You will, if you're, you know, in this practice, you will refer to these people.
And not that we're, I mean, opposed to, you know, referring to other people, but to get started, we have to, you know, have a protocol, and then we're always open.
We're actually opposed.
No, not really, because I mean, for example, we have a new implant clinic in town, and they're attached to one of our oral surgery offices. Well, that oral surgery office wasn't one, I mean, we referred to that oral surgery office and another oral surgery office, but one of the doctors, one of our associate doctors, has been taking implant, you know, training and stuff from this implant institute. So absolutely he can refer, you know, some of his implants over there, whatever he wants to do. So that's something that wasn't in our handbook that we talked about, but that's something that, we've talked about and we've, you know, added in there now, because when he started, there wasn't an implant center, you know, here in town. So that's just something that, for an example, that things can change or be added. It's not that we're like, nope, you can only refer here and nowhere else, and we're never open to any ideas. It's you have to have something laid out to get started.
Right, exactly.
The other thing that the handbook outlines is equipment that we use in the office, as well as materials, instruments, and things like that that we provide. One of the biggest mistakes I think that some offices make is letting the associate come in and order whatever equipment that they want or instruments that they want to use. Materials, for example, impression material, cement, different things like that.
A lot of docs will say, well, that doesn't work in my hands, or I don't know if that's going to work in my hands. Well, you're going to try it for a while, and we'll figure it out, because obviously we've made it work and we've been using it for a long time.
And that goes back to like what I said with the specialist. We're not opposed to anything, but we give it, just like any of our other team members are on a 90-day trial period. They have to try everything in our office for 90 days and then come back to us with if they want to change. But our deal has always been. I've never
had anybody after 90 days say, nope, can't use that. You
know, there's just been a couple circumstances, but our deal is, you know, it can't be more expensive than what we're using. So if you want to change to something, it has to be what we're already spending or under, is kind of what our protocol has been for that. But we haven't, for the most part.
Once they use it for 90 days, they're totally comfortable with it, is what happens.
Yeah. So it just outlines every aspect of the office: patient care, hours that the office is open, and then there's a spot for the hours that they're working.
Right. That they have to be at team meetings, that's required.
Yeah, just it overlays everything that we expect of them. So when I was saying in the beginning, set down your expectations of what you expect of them, and that's how we made ours, is the associate handbook. And they all get that and sign off on it. And that's relieved a lot of headaches for us when it comes to setting expectations.
Right. Well, the other cool thing is, once you've tried this once, I mean, one of the reasons that we're talking about this today is because I had a good friend that just hired her first associate, and it was fairly traumatic for her, because she's never had to share patients. She's never, you know, had to, introduce her patients to somebody else that was going to take care of them. And it's been really, really tough for her. And she's very, very, very meticulous about how she takes care of her patients and all that kind of thing. And which is one of the reasons why she wanted to bring an associate in, because she's kind of, stressing herself out quite a bit because she's so meticulous. But she said, I said, the very first thing I said to her is, you want to lay down a training protocol for what you want to teach this guy. And she said, yeah, I'm just afraid I'm going to offend him. And I said, well, if you offend him, you either haven't set the expectation up right, or it's not the right guy. So you want to, when you talk to somebody, when you interview them, you want to say, hey, we do things certain ways in our practice. Are you open to learning the ways that we do them? Are you open to having training for that? Are you open to sitting down with me and learning what I've learned over the last 15 years or however long, So he is. I mean, he's very willing to do that. And so she's actually sat down with him and made time with him every single week to sit down. And even though she's got 4, pretty young kids and she's busy, but she's made time to do that training. And she said it's really, really helped. And we've even talked back and forth a little bit about kind of what things she wanted to talk about and, how she approached him with certain things. And really the thing that he needed the most help with, and which I think is going to be most associates, is communication with patients and how to talk to patients and what to tell them. And it's something we just don't get in dental school. They don't teach us what we need to know.
Well, and I think that if you're going from, like you said, a female doctor to a male associate, or a male doctor to a female associate, I think you have some more, hoops that you kind of have to jump through there in bringing in that new person. Because if women, for example, if they've always been used to seeing female, some patients have an issue with that, and vice versa.
The guy that she hired is a pretty big guy, So I mean, she's this little tiny woman, and this is a big guy. I mean, just the physicality of it is going to be a little bit different for them.
Yeah, and vice versa. I mean, male doctors hiring female associates. I think it's fantastic to have both and the complements of both in your practice. Yeah. But I think that during that transition time, you may have some patients that are a little bit more, kind of put the brakes on to it.
Right. But the easiest way, though, to transition the associate into your practice when they first get there, is to take them into hygiene either with you or, have them, introduce them to as many people as you can every single day. Take them into hygiene, have them check the patient and say, hey, Mrs. Jones, I know that, I've always done your hygiene checks, but, and I've always been your dentist. I'm still here for you. I still want to take care of you, but this is Dr. Smith, and he's going to take care of you today if that's okay with you. Mm-hmm. And just introduce him that way and just say, he's new to our practice, but he's a great doctor, and he's really going to take great care of you. And just give him your endorsement is really all you really need to do. But go into hygiene together and just meet the patients together.
Yeah, and I think you need to do that as much, physically in front of the patient as you can. Mm-hmm. I know a lot of times there's a letter sent out or a little,
I would shy away from sending a letter, as a matter of fact. I would have them meet, just introduce them when they're in person.
Yeah, and I mean, a lot of times have something, on the front counter or something, like a frame thing that says, we're happy to introduce, and then whoever it is, and then once you've gone through a little bit of that physical, then send out the letter or put the ad in the paper, that we're introducing so-and-so to our practice, we're so excited to have them, but really making sure that you're going through the process of introducing them physically or when they're in your practice first.
And know very clearly, too, that a lot of times we have hangups that are not our patients. So if we're concerned that, they're right out of dental school, a lot of times patients, they don't even know that, nor do they care about that kind of thing. So that might be something that you're concerned about or that the associate's concerned about, but the patients aren't really concerned about. And it's certainly nothing that you need to bring up right away.
Yeah, absolutely. So going back to how do you structure, bringing that in? What does the schedule look like? How does that work?
Right.
And I think that's something that you need to sit down and decide, is it the associate coming in because you want to cut back your days? Is it something where you're going to do a split shifting type thing? Everybody's situation is kind of different on why the associate's coming in. I mean, obviously there's a need for one, but how it's going to be structured, and just really make sure that it works for you. And that you're not, the associate's not working.
And it doesn't shake up the team too much, too. I think that's one of the big things. I mean, the team's going to embrace it a lot more if they don't feel like they're working 10 times as hard because you brought in a new doc.
Yeah, so just make sure that you have a laid out plan of, how the schedule's going to work and all of that and the hours.
Interesting thing, though, a lot of offices that we've found that have added an associate, really all they've had to add is one extra dental assistant. I mean, they actually have enough help at the front, they have enough hygiene, they really just need, if you're truly busy enough beforehand, that's probably about all you need to add, is just one dental assistant. That would be the goal, would be to just try and hire just the one dental assistant to add in. And then of course, if you're busier than that, then you'd want to have 2 assistants per doc, or however you want to structure it. That's certainly something that would be a little more customized as well.
The other thing that we just kind of touched on, but I think is super important, is scheduling out time every week to meet with the associate doctor. Just, docs meetings. I mean, we have a docs meeting once a month now, but when a new doctor is starting in our practice, I mean, if not daily, for sure weekly, that we're meeting, on a one-on-one basis with them.
Right, if you already have a lunch break in your office, of course that would be a perfect time. We don't do like a specific lunch break. We keep the office open pretty much all the time. But honestly, that's a great time to just kind of say, hey, let's just make sure that we sit down and have lunch a couple times a week at least, or something like that. Yeah,
and it just keeps, on the same page. What are they having issues with anything? It just really keeps that communication line open between, the docs and, team or whoever.
Right.
But I would say at least an hour a week that you're sitting down, making sure that everybody's on the same page, things are moving in a forward direction, and if there's questions or, different things. And I mean, it may just be, I saw Susie today, and Susie was super sensitive about the anesthetic that we use. Is there anything, I need to know about her? And a lot of times, like I said, it's on a daily basis because the associate's going over their patients, and a lot of times they're seeing patients that have been of record.
Right.
So what I say, at our huddle when...
Yeah, it'd be ideal if they just got to see all the new patients, and then they didn't have to see any of the existing patients.
When our team members, front office is going over, anything we've found out about the new patients over the phone to our clinical team, I think it's kind of the same. The docs need to have their own mini huddle, maybe before the day or the day before on the next day about, these patients, is there anything special that I need to know that's not, in the notes, or what we call green notes that are, personal, about the patient that can kind of get them up to speed, and I think that's really important.
Well, and one special thing that we do in our practice too, that we have really taught the associate doctors how to do, is just basically how to talk to patients, and spending a lot of time with our associate doctors how to talk to patients. And one thing that we're really, really specific in our practice about what not to do, because patients get so confused by it, is we're really clear that they don't get to talk and use really technical terms with patients. I mean, they can explain, certainly what a root canal is to a patient, but they need to explain it in terms that the patient can understand. So our rule is kind of, kindergarten to 3rd grade language as much as possible. And as a new doctor, sometimes, I remember I felt this way. I wanted to explain it to people in all the bright, shiny new language that I had, that I just learned in dental school, and I wanted to impress people that I was smart enough and I knew what I was doing. And really that backfired a lot on me, because patients just didn't understand, and so they really can't accept treatment if they don't understand what you're talking about.
Yeah, so just making sure that, I always say, your lead dental assistant should be working with your associates starting off for that 90 days, so that they are getting things under their belt and figuring out how the office runs, how everything's running, because it's just like any new team member. It takes them a little bit to figure out the systems, to get things
and
going.
The more assertive that assistant is, the better off you're going to be, really. I mean, if that assistant can say, try it this way, or, and just get permission from the doctor that, hey, I'm going to try and help you out as much as I possibly can. Is that okay?
Yeah, and just really leading them through the steps is what that assistant is doing, and getting them comfortable with the office. And like in our office, the assistant does a lot of the case presentation and information gathering and all of that. And so, we have a specific system for that. The doctor doesn't do a lot of
Hopefully the doctor just comes in and kind of shakes his head yes and confirms and does a lot of that.
But I mean, not to go into, every type of personality, but if you have a doctor that does, like to go over more of the, treatment and do the treatment plan presentation and all of that, then you do have to make sure that you're using, those word skills and word pictures, and just making sure that the patient is understanding, because if they are an existing patient, they are already a little bit fearful about seeing someone
again? That's pretty good.
Yeah, my words got
I want to see that again.
They're already fearful about seeing a new doctor, and then, when somebody, comes out of the chute being all technical on them, it scares them even more than they were in the beginning, like, oh my gosh, somebody new. So we really just focus on especially that new doc, building their own relationship with those patients as well.
And we teach the docs, get to know them a little bit. Tell them about your family. Tell them about how you got here. Tell them about, you're new to Des Moines, or you're new to the area, or you're, whatever. Talk to them a little bit and, find out, ask them for their recommendation about something, or, just talk to them like they're a human before you really get to the teeth.
Yeah, so I think the biggest thing is just really making sure that you set down expectations for them so they know what to expect, they know the office protocols, making sure the structure or the schedule, everything is down as well, and then just really leading them through, how your office does things, and making sure that they, that communication line is open and you're meeting on a regular basis to keep moving in a forward direction. And
one big thing, and this may kind of seem like it's backing up a little bit, but one huge question that we get from a lot of doctors is, how do I structure the contract? And you definitely want to have somebody do a contract. We use AFTCO for all of our contracts because they've been with us for a long, long time, and they've been really crazy helpful for a lot of stuff. But if you can possibly swing it so that doc can be an independent contractor, if it works with your state, if it works. In our practice, our docs are independent contractors because it saves self-employment tax and it saves all of that payroll tax. And that's a huge, huge benefit for not only the office, but for the doctor. So there's just a lot more benefit to structuring it that way rather than an employee doc. If you can get away with that, that's really, really helpful. Check, obviously, the laws in your state and check with, an accountant or an attorney and whoever you need to, but that's been really, really helpful for us. And a lot of people will say, well, that's not allowed in my state or whatever. And I disagree. I think that really, truly, associate doctors are independent contractors, no matter how you really define it, because it's really very, very much they get to kind of do and work the way that they want to. It's, sure, are we setting the hours? Kind of, but our associate docs really get to kind of, set their own hours to some degree as long as they fit in with the office hours. But ultimately, I think the independent contractor fits a lot better.
Yeah, from a liability standpoint and everything. And
right.
It's just make sure that you're talking to your accountant and your attorney, as well as, whoever's drafting up the contract, to make sure that you are in, guidelines with your state or whatever the case may be. But we really highly recommend going that independent contractor route versus an employee.
Right, exactly. What else? What else can we think of that we've run into with associates? Oh, one of the major things with associates is that we want to make sure that they know kind of the proper channels what to go through if somebody comes to them, or a patient comes to them, or a team member comes to them, who to sort of funnel it back to. One of the things that happened in our practice quite a while was that the team member would go to the associate doc and sort of unload, a problem they had or something like that. And interestingly enough, the associate doc and the team member knew that wasn't the proper channel, but they were sort of either venting or something like that. And what we really ended up having to do is make sure that everybody knew that the protocol was, talk to your team leader first, or the associate doc knew that they just needed to say, hey, I'm happy to listen, but that the proper protocol is to go to your team leader with this type of thing, or you need to go to Dr. Mohan with this, or you need to talk to somebody else about it. So make sure that you're definitely training them, the associate docs, to push things and information in the right direction, and certainly complaints in the right direction.
And all of that should be laid out in that associate handbook, which we talked about earlier. That's one of the things in there is
that's a big thing in there.
If there is a problem with a team member or a patient or whatever, how does it work? Who do they go to? And just really making sure that you're all on the same page. And that's why I say that weekly communication is absolutely critical, not only with the team, but with the associate when they're just starting and getting on board. Because a lot of times, the team has a little bit of an issue as well, like your patients do at first with the new associate doc or the way they're doing things. And really, it's just because they're needing some guidance. It's not they're a bad person or they're, doing something wrong on purpose. It's just that they need some guidance. And so making sure that communication channel is open between the associate and, the team leader or the owner or whoever, and also the team members, that they know that there's also, a communication channel for if there is a problem with the associate,
Sure.
how that works. Because
Right.
a lot of times the team members will see them differently.
They see them as a leader whether or not the associate doc sees themselves as a leader.
Yeah, and so sometimes if there is a problem or there's something going on with a patient or whatever, the team member feels a little bit uncomfortable bringing that up or to the table. So that's all laid out as well.
Yeah. So one of the last things that I want to talk about is, what do you do when you really like the associate doc that you have there? What do you do to keep them long term? How do you make this something that's not a revolving door of associates? So, and especially, I've had a partnership that, partnerships are very, very difficult in dental offices, dental practices. Ultimately, unless two people are pretty, sure, whatever, about decisions, usually one person is going to feel a lot more strongly about one thing than the other. And so partnerships are very, very difficult. So the associate model works really well in really two cases that I can think of that you really can keep that associate doctor much, much happier and much longer than you might have been able to. One is that you want to make sure that your new patient flow and just your general patient flow, that you have tons of patients and you have plenty for that doctor to do. That doc is going to stay a lot longer and they're going to be a lot happier, and just mainly because they're making more money and they're busy and they're happy. So that's, just having plenty of patients is probably the very first thing. The second thing that I would say, and I do this very well, is that anytime that there are ownership issues that come up, things that happen in the practice that the associate doctor isn't dealing with, you want to make sure that you actually let them in on some of those things that happen when you're an owner doc. If something breaks in the practice that's $5,000, let the associate doc know, hey, this broke. This came straight out of my paycheck. This came right out of my pocket. And granted, we have budgets set up for that kind of thing and everything in our practice, but we want them to know that ownership is a big challenge and it's something that they shouldn't go into lightly. And I think a lot of people, I think that's why a lot of dentists have some issues with being owners, because they didn't enter into it.
I think it goes back to like what we said. I think partnerships, associateships, associate to own, all however it's laid out, that I don't think really matters.
Yep.
It's the expectations of what you expect of each other, what we expect of the business, our vision, our everything is in line, and it really does. None of that has been spelled out and nothing, and I go back to this no matter what it is in the dental office. If it's not in writing, it hasn't been done.
Yep.
Because it's just like financial arrangements. If you're doing verbal financial arrangements, and
that's up to way too much interpretation.
Sally that did them, she, God forbid, would get hit by a bus tonight, but say something happened to her and she's no longer there. What would happen? Same with the associate doc or the partner doc or whoever it may be. If something would happen to either one of you and it's been a verbal arrangement, there's nothing that will hold up to that.
Right.
So from a business perspective, everything needs to be in writing, and that's why I'm huge on these team agreements and associate handbooks and everything, because it has to be all laid out there of what's expected of each other, what our vision here is, and it goes back to the business and patient care is ultimately what it comes back to, and we're doing all this so we can make sure that we give our patients the best care, and make sure that our office runs smoothly, and at the end of the day we're not pulling our hair out.
Well, and if we're worried about turning our patients over to another doctor, then you have to spend that time training the doc. You have to talk to them about whatever you can to make it easier to transition for your patients. So like simple things. This is great. One of my associates the other day was having trouble with some sensitivity. Patients were having some sensitivity with composites. Not a huge issue for, that we deal with all the time, because we've been doing this a long time. But I told him, I said, here's the thing. What do you say to the patient? Do you tell him that it's going to be sensitive for a few days? And he said, yeah, that's what I usually tell him, maybe a few days to a few weeks. And I said, well, what if you told him that it was going to be sensitive for a few months? And he said, that's a good idea. And I said, well, yeah, if you tell them it's going to be sensitive for up to a few months, or, it could be sensitive for a few months, and then they're only sensitive for a week or two, then the patient feels pretty good about it, right? But if you tell them it's going to be sensitive a few days to a couple weeks, and they come back 3 weeks later and it's still sensitive, they're freaking out. But if their expectation was different, then you've covered all your bases and you're okay. And that's true. I had something done in my mouth that was sensitive for an entire year, and it did kind of freak me out a little bit. After a while, I thought, gosh, am I ever going to be able to chew on that tooth? And it calmed down eventually, but I found out that I'm just more sensitive than some people.
And that's, I mean, I'm the same way. I mean, my teeth are super sensitive, and no matter when I have anything done, I'm a little bit out of the norm when it comes to what the, you know, guidelines should be for something. And so I think it all depends. If you set the expectation for the patient, you know, that this may happen.
It's
and
not out of the realm of normal to have something be sensitive for a year. My tooth was sensitive for a year. Is it fine? Sure. It's totally vital. Totally fine.
Yeah.
So anyway, but he just, his eyes got really big, and he said, wow, that's such a great idea. And I said, but that's something that you learn over time. That's why you want to sit down with those people and say, you know, with your docs and say, look, I want to make this easier for you. And I want to make it less, you know, conflict for me and the team and the patients and you. And that's why you sit down with them and say that. So, you know, set their expectation. You know, a crown is, you know, we always say it's 2 visits. Well, maybe it'll be 3. So, you know, up to 3 visits, or you know, whatever you want to say. If it's a CEREC and you say it can always be done in 1 visit, well, can it? Or sometimes you have to temporize. You want to set the expectations so that it's, you know, you get a better result because the patient was set up correctly.
Yeah, absolutely. So if you have any questions about hiring an associate, structuring things, anything, feel free to contact us, and we are always here to help with whatever questions or anything that you may need.
Well, get out there and love your practice, and we are excited. We'll see you next time.